This is a great opportunity to see everybody outside of clinic. Hello. As part of our efforts over the last few years to focus in on some new issues that are applicable to many individuals with not only hemophilia but bleeding disorders, we're doing the occasional session, and we had this fantastic opportunity to capitalize on someone who's got some expertise in a very common problem, osteoporosis. And so we took the opportunity to invite her to speak, and I'd like to introduce her today. For those of you who may not remember me, I'm Shannon Jackson. I'm a hematologist here at St. Paul's and involved with the Hemophilia Bleeding Disorder Clinic for BC. And I actually trained in Calgary, where Dr. Lee heralds from. So Dr. Adrienne Lee is a hematologist and currently a hematologist just finishing up a 2-year fellowship in hemostasis, specializing in bleeding disorders and hemophilia. And she trained both in a little bit in Edmonton, then in Calgary for both her internal medicine and hematology training, and is very well poised to give you a talk on something that has interested her for, I think, about 2 years now. And she's become very interested in the effect of bleeding disorders, specifically hemophilia, on bone health and the development of osteoporosis. And she's going to share with us today some real insights. And we're actually quite thrilled in BC to have been able to participate in a study that she started in Calgary with a number of osteoporosis experts, people who are recognized nationally and internationally in osteoporosis research. And so that was sort of the touch point that we decided to ask her to do a talk about osteoporosis. So I'll turn the table over to Adrienne, and thank you so much for sharing your insights. And please don't be shy. She loves questions after. Thanks, Adrienne.
All right. Thanks, Shannon, for that introduction. So welcome, everyone. Thank you for coming to this session and to learn a little bit more about bone density and bone health in hemophilia. And feel free to ask me questions as we go along, but I'll try and leave as much time as we can to have some interaction and have some questions too. This talk is being videotaped, so I hope that's okay with everyone. It's mainly a videotape of me. But if you do ask any questions, I believe the camera does pan so that we can also see you. There are microphones close to everyone's seats, and when you have a question, if we could ask you to please just press that button when it turns, I believe it turns red, a light comes on, and that means that microphone is on and we can actually hear you speak, okay? So I am from Calgary. I'm originally from Vancouver. I was born and raised here, went to medical school here, and then did my training in Edmonton and Calgary, and right now just finishing up some fellowship training with Dr. Poon in Calgary. So I'll just get started here. So I don't have anything to disclose for this talk. The only thing I was going to say is that my fellowship training is supported by the Bayer Hemophilia Award Program. And this is hemophilia as we used to know it. And this is still the picture of hemophilia in a lot of developing countries where there's no comprehensive care and there's poor access to factor replacement. And this really is not what we see now in developed countries like Canada, the US, and the UK. We see our children like this. They have comprehensive care. They have factor prophylaxis that brings them their factor levels back into the normal range and allows them for more sort of regular physical activity that we expect our children to have. And that really bodes to what I was talking about, prophylaxis and comprehensive care, the ability to do home infusions and to treat bleeds early and try to prevent joint damage. So we know from this joint outcome study done by Manco Johnson that with primary prophylaxis, so prophylaxis that started at the time of your first bleed or before the age of 2, before joint damage really takes place, there's fewer bleeds that happen and patients have healthier joints. Not only do they have healthier joints, they have better quality of life. And you can see this is pictures from camp in Calgary of kids doing all the regular things that kids should be doing. And not only do they have better quality of life, patients with hemophilia are living longer. So before 1940, before we had any real treatments available, the average lifespan of a patient with hemophilia was about 10 years old. And before 1970, the only treatments available were plasma products and whole blood transfusions. In 1964, Judith Graham-Poole actually discovered cryoprecipitate and found that cryoprecipitate had high factor VIII levels in it, high concentrations of it, and that started to be used for treatment of bleeds and for hemophilia. And the average age to time of death in the 1970s was about 40. And then came sort of more concentrated clotting factor products. It came as freeze-dried components, and they were all plasma-derived, so from multiple plasma donors. And at that time, there was no viral inactivation. And unfortunately, in the 1990s, we had a drop again in the average lifespan of hemophilia patients. And we lost a lot of patients to bloodborne diseases like hepatitis C and HIV. And in the 1980s was when we finally were able to sequence the factor VIII gene. We were able to make recombinant factor VIII. We virally inactivated our plasma products. And now, a child born with hemophilia who receives recombinant products and potentially gene therapy, we expect them to have a normal lifespan. So this is sort of the age distribution of our patients in Calgary. Majority of them are young. We can see that there is a portion of older patients, but we really don't know what kind of comorbidities, what kind of other medical issues could hemophilia patients develop as they get older? Are they the same as the general public? Well, it appears that there are some issues, some medical issues that are more prominent in the aging hemophilia patient. And some of you may have participated in Dr. Jackson's study that looked at cardiovascular disease, cardiovascular risk factors in hemophilia patients. Hepatitis is common because of previous infection with hepatitis C or hepatitis B, but also musculoskeletal issues. And this is probably something familiar to the older hemophilia patients, to adult patients who did not receive primary prophylaxis, who did not have regular infusions of factor, and may have developed recurrent joint bleeds and therefore chronic joint damage. And naturally, as people get older, and I'm sure some of your partners or spouses or friends may speak to this who don't have hemophilia, those joints start to get a bit creaky. Those joints start to get some osteoarthritis in it. And so musculoskeletal issues like arthropathy, hemophilic arthropathy, can be compounded by things like osteoarthritis. So really, we're going to talk more about musculoskeletal disease in hemophilia patients. And the one that's very evident that you can actually see and you have symptoms from is joint arthropathy. But there's also evidence of low bone mineral density happening in hemophilia patients. And this is more of a silent process because you don't really see low bone mineral density. There's no symptoms of it. And it might be that the two go hand in hand. So this is just a picture of hemophilic arthropathy. You see the normal joint on your right-hand side. The cartilage is quite clean. You don't see a lot of erosions in the bone. And then hemophilic arthropathy on the left there, you see the bone is more jagged, more irregular. But not only that, this bone appears a little more less dense than the normal joint. So maybe there's a connection here. But let's talk about what bone mineral density is. So the definition it's the amount of mineral per square centimeter of bone. Okay, so density of a bone is an important factor in the strength of the bone and its ability to resist breaking or fracture. We do know there's a statistical association between poor bone density and the probability of fracture. And most of this information comes from epidemiologic studies in postmenopausal women, which we know that population has a predisposition to developing low bone mineral density. So in general, people with lower bone mineral density have a higher risk of things such as compression fractures or spine fractures, pelvis and leg fractures, especially if they fall. And this is one of the major public health concerns in postmenopausal women, and there's a lot of research in this population. So how do we measure bone mineral density? Well, we measure it by a machine called a dual energy X-ray absorptometry, or DEXA for short. And sometimes you'll see this referred to as the bone density scan. If you order it, some physicians will say, oh, I'm sending you for a bone density scan. This is what you're getting. And you can see on the left there, that's what the machine looks like. What it does is that it gives you a small amount of radiation, and it measures the density of your bone relative to, based on how much radiation or energy is absorbed. And what has been developed is a scoring system. So there's a T-score and a Z-score. And this is how bone density is reported. So the T-score gives you a measure of how dense your bone is relative to an average healthy person of your same age and sex. So what do we know about the normal life cycle of bone? So what happens as you grow up, your bones get bigger, you get taller, and you start to lay down more and more minerals, so calcium and phosphate that's making up the bone. And what happens is as you grow, you reach a peak bone mineral density or a peak bone mass around the age of late 20s to 30s. And that's sort of as dense as your bone is going to get. After that, we know with age there's a gradual decline in the bone density. It's just a natural process that happens. For women, it's a little bit different. There's a gradual decline until they hit menopause, and as they lose the estrogen, they actually have a very rapid drop in their bone density. Estrogen is known to be protective from bone loss, so as they lose the estrogen, they just have a rapid drop in bone mineral density, and that's why this population is predisposed to things like osteoporosis. Men, on the other hand, generally have a very gradual drop in their bone mineral density as they age. So does having low bone mineral density mean you have osteoporosis? Well, not necessarily. Osteoporosis is a bone disease. It's caused by low bone mineral density as well as a deterioration of the bone tissue. Okay, so something has to cause that bone tissue to become abnormal for the microarchitecture of the bone to be weaker. And that's often due to processes that cause more rapid loss of the bone. So low bone mineral density, we use it as an indirect marker of osteoporosis. According to the WHO, we define osteoporosis as a T-score less than minus 2.5. And that generally translates into a higher fracture rate. So when we say high fracture rate, we say greater than 20% risk of fracture over 10 years. But any one individual's true fracture risk is dictated by more than just their bone density. So a T-score of minus 2.5, which would be in the osteoporotic range for a 41-year-old male, does not mean that he's at the same risk of fracture as a 78-year-old female with the same T-score. There's a lot of other factors at play, such as how active are they? A 78-year-old female may be at higher risk of falling and fracturing than, say, a 41-year-old male. Are there underlying genetic factors, hereditary factors? Body mass. Body mass is generally protective against fractures and low bone mineral density. Hormones are at play, so estrogen in females, and also your intake, the building blocks for your bones, so calcium and vitamin D. Are you getting enough of that? That plays a role in how the quality of the bone that you have and how well it can resist fracture. And the other thing is bone is not static. it is dynamic. There's normally a balance between bone formation and bone resorption. Your bone is constantly turning itself over. There are cells that cause the bone to form more bone, and at the same time, there are cells that break down the bone. It's in this constant cycle of sort of remodeling and rebuilding itself. When you're growing up, when you're a child, and in your teenage years, your bone formation cells are really active. They're really working hard to lay down your bone. After age 30, those bone formation cells start to slow down, and the cycle sort of stays relatively stable. The bone formation cells and the bone resorption cells or the bone breakdown cells sort of stabilize each other out. And only if there's some additional factor that upsets that balance, then we can fall into bone disease, where there's more rapid bone loss, and that can lead to early osteoporosis or low bone mineral density. So how is it that we started looking at bone mineral density in hemophilia patients? The first report was in 1994 by Gallagher and his colleagues in the UK, and he noticed that 2 of his young hemophilia patients had unexplained fractures. One had a compression fracture of his spine, and I believe he was only 20 or 21 years old. And another patient had a hip fracture, also about the same age. So he decided to look at a cohort, at a group of severe hemophilia A patients, and measured their bone mineral density using the usual DEXA scan or bone density scan, and found that these patients all had significantly lower bone mineral density compared to their age and sex match controls, or a normal healthy population of the same age. And then so that prompted a whole bunch of other studies to be done to see, is this true, or is this just a one-off study that found low bone mineral density in hemophilia patients? So a meta-analysis done of multiple studies, so 7 studies here, but there are many more that have been done, that looked at bone mineral density in both children with hemophilia as well as adults with hemophilia. And the conclusion of this meta-analysis is that it appears to be real. There really is lower bone mineral density in hemophilia patients compared to normal healthy individuals. So what do we know from all these studies? So in adult hemophilia patients, low bone mineral density is detected in approximately 70% of severe hemophilia patients. Osteoporosis range bone mineral density, so that's the T-score less than minus 2.5, is found in 30% of severe hemophilia patients. And 50% of severe hemophilia patients who have low bone mineral density are under the age of 35, so quite young. So what does this mean when our hemophilia patients start to get older? And there are a lot of unknowns that are left behind. So what is causing the lower bone mineral density in hemophilia? Does the lower bone mineral density in hemophilia males actually mean the bone is weaker and at risk of breaking? Is hemophilia causing more rapid bone loss for some reason? And if the bone mineral density is low in young men with hemophilia now, will they be at higher risk of bone fracture as they get older? And what can be done to protect against bone loss and fracture in hemophilia? So I'll try to answer these questions. So what is causing lower bone mineral density in hemophilia patients? Well, we don't really know, but there are theories out there. The biggest one is inactivity due to recurrent joint bleeding and arthropathy. So young children who are getting recurrent joint bleeds are going to be less active. They're not going to be out there playing soccer, running around. And we know that activity is really important stimulus for the bone to form, to mineralize, and to become very strong. So there's a theory that maybe hemophilia boys are not able to achieve the same peak bone mass as their healthy counterparts. Other additional factors are things like liver disease or active viral infections. Some of the medications used to treat HIV are known to cause bone mineral loss. And then also, there may be loss of bone due to cytokines or inflammatory chemicals that get released during a joint bleed or with chronic synovitis. And there's a lot of signaling that happens in and around the tissue and the bone. So these cytokines that are released may actually influence those bone-building cells and those bone breakdown cells in a way that causes that balance to be offset. So does the lower bone mineral density seen in hemophilia actually mean the bone is weaker and at risk of breaking? Because I told you earlier, low bone mineral density doesn't necessarily mean osteoporosis. There's other factors that are at play in terms of risk of fracture and weakness of the bone. And if we think about bone strength or strength in general, strength is dependent on structure. And one thing that contributes to structure is the material. So for bone, that's your bone mineral density. But the architecture is also really important. So bone is made up of sort of two different components, the cortical component, which is the outside portion of the bone, and the trabecular bone, which is the inside portion of the bone, where all the bone marrow cells sort of live. And if you have poor architecture, even if your material is strong, it can still break. And this is a picture of what osteoporosis, osteoporotic bone looks like. You can see the architecture is completely different. So going back to this algorithm, our DEXA, or our regular bone density scan, can tell us about bone mineral density. That's about it. It tells us about the material. It doesn't tell us anything about the architecture. Now, this new HRP-QCT scanner, or to abbreviate, I like to call it the Extreme CT. It's a 3D CT scanner that can give us 3D images of the bone and the architecture of the bone. And the great thing about this is that it can tell us about the bone mineral density, but also gives us information about the architecture. And it's a high-resolution scan. It's able to examine the bone at the microarchitectural level in 3D, as you can see here. It can separate out the trabecular bone and the cortical bone and analyze these components separately. Can determine how dense each of those components are and how porous each of those components are. And the other great thing about this is that there's computer algorithms that can use the 3D reconstructed images to calculate how much force is needed to break that bone. And that's what we really want to know. We want to know, based on the material, the density of the bone, as well as the architecture of the bone, is that geometry weaker in hemophilia patients or not? So this is something called the failure load. The image in the middle is sort of a real mechanical way of testing bone, so that the strength of the bone. So that's actually a piece of bone there that they put between two metal plates, and a force is applied to that until it breaks. And obviously, we're not going to do this to you patients. We're not going to take out a piece of bone and find out how much force we need to apply to it to break it. But this 3D CT scanner can do that. It can use the computer algorithms to calculate that force. So what do we know? We started a small pilot study in Calgary and scanned about 16 of our patients, moderate and severe hemophilia patients, both A and B, and looked at their architecture. And what you can see is, compared to a normal patient of the same age, the hemophilia patient has much thinner and fewer trabeculae, and you can see that the architecture is not the same. And when we did that computer algorithm to determine how strong that bone is, you can see the normal patients are in the blue and the hemophilia patients are in the orange. They have a weaker bone. That means less force was needed to be applied to that bone to break it. So it appears that the lower bone mineral density in hemophilia patients could translate into a higher risk of fracture. So is hemophilia itself causing more rapid bone loss? Well, we really have to look at the dynamic part of bone metabolism, because the DEXA scan, the bone density scan, and the extreme CT scan only gives us a static image. It's just one time point picture of what the bone looks like. We don't know what is happening over time, really. So we have ways of testing this. We look at blood and urine tests that can measure the byproducts of both bone formation and bone breakdown. And we can sort of determine, is there an imbalance? Is there too little bone formation? Or is there too much bone resorption, too much bone breakdown? Or is there both? So in the pilot study, 12 of those 16 patients, or 75%, actually had either increased bone resorption and or decreased bone formation. So this suggests that there is some abnormality in the bone metabolism in hemophilia. Why this is, I don't have an answer for that yet, but it seems to be causing some more rapid bone loss. So if bone mineral density is low in young men with hemophilia now, will the risk of bone fracture get worse as they get older? Well, presumably yes, because we know that's the natural history of bone mass in humans, but we do need more studies and more data to answer that question. What we really need to know is to measure bone density in hemophilia patients longitudinally or over time. We need to know, are they really losing bone density more rapidly? What is the fracture rate as hemophilia patients get older? So it's important to learn about this now in order for us to prepare for the possibility of these higher fracture rates in the future. So what can be done to protect against bone loss and fracture in hemophilia? Well, there's no guidelines. We're just learning about this now. There's some expert recommendations, but it's based on pretty limited evidence. So there is suggestions that screening should be done in all severe and moderate hemophilia patients using a bone density scan as a baseline. We should be checking vitamin D levels to make sure you're not deficient, and if you are, these should be replaced. And treatments can include things like vitamin D and calcium supplements. Other commonly used osteoporosis medications for postmenopausal women, we really don't know if these work in hemophilia and what the indications are. Presumably they would also work, but we just really don't know the application of these treatments yet. But the way I see it is that there's sort of three main components to protecting yourself against low bone mineral density. The first is to optimize the management of your underlying condition, which is hemophilia. So being in a comprehensive care clinic, coming to your regular clinic evaluations and visits, being on prophylaxis, preventing bleeds, and early treatment of bleeds to prevent that arthropathy from developing, to prevent that chronic synovitis. Because like I said, there might be some inflammatory cytokines or inflammatory chemicals that are causing this more rapid bone loss. Also, healthy nutrition is important. You want to have a balanced and nutritious diet. You need calcium and vitamin D in your diet. And then also regular physical activity. So calcium, what are the recommendations? And a great resource is this Osteoporosis Canada website, and you can get a lot of information there. So typically, people between the age of 20 and 50 need about 1,000 milligrams of calcium a day. If you're over 50, the recommendations are 1,200 milligrams. And in general, you need about 2 to 3 servings of milk products or milk product alternatives per day. So 1 serving of milk per meal is a good rule of thumb. Oh, that came out a little bit weird. I just wanted to give you an example of some of the calcium sources. So milk, buttermilk, generally these are the highest calcium containing food products we have. 1 cup has about 300 milligrams of calcium, so if you had 1 cup of milk with every meal, you'd get about your recommended 1,000 milligrams a day. Things like beans, collard greens, cottage cheese, tofu, all contain calcium as well, but you probably have to eat a bit more of that to get your daily calcium intake. And so that's why there's calcium supplements out there that can be used as well. Vitamin D. So vitamin D comes from the sun. Your skin will naturally make vitamin D as it's exposed to UV light. But a lot of us in Canada don't get enough UV exposure and are commonly vitamin D deficient. There's not a lot of food sources that have vitamin D. Things like oily fishes, cod liver oil do contain some vitamin D, but probably not enough. So most healthcare professionals do recommend some sort of vitamin D supplementation. Healthy adults between the age of 20 to 50 need about 400 to 1,000 units of vitamin D a day. Adults over 50, a bit more, up to 2,000 units a day. And what you want to do is look for products that say vitamin D3 or calciferol. This is the vitamin D that's best metabolized by your body. It is fat soluble, so that means if you miss a dose of vitamin D, you can actually make it up. So if you missed one today, you just double up on your next day. And then regular physical exercise. But what type of physical exercise? Not all physical exercise is the same. There are mechanoreceptors within your bone that triggers the bone-building stem cells to form new bone. And the best exercises are weight-bearing activities or activities with high ground reaction force. And what this means is the force applied to the ground is the similar force that's applied back to your body or to your axial skeleton. And these kind of activities have the most osteogenic or bone formation potential. So things like jumping, running are activities that have these high ground reaction forces. But in general, any kind of physical activity is going to be good because not only does it improve your bone health, it improves your overall health, it improves your balance, it strengthens your stabilizer muscles. So it doesn't only protect you from joint bleeds, but probably protects you from falls as you get older. So just a little bit about this study. So using extreme CT scanner to investigate low bone mineral density. So we're starting an expansion of this pilot study and recruiting in both Calgary and Vancouver. And some of you may have probably received this in the mail already, a letter introducing this study. And our goal is trying to scan 90 persons with hemophilia, any severity, using this scanner. And the components of the study are sort of 5 big ones. One is the clinical assessment, where we just want to collect information about your type of hemophilia, how severe, have you ever had fractures, are you taking vitamin D or calcium. Then there's the joint score, because we want to know how much arthropathy is already there, as that might influence your bone mineral density. Blood work, so you will be asked for a blood sample and a urine sample. And then the 2 scans, so the regular bone density scan, which is the conventional assessment, and then the extreme CT to look at the microarchitecture and the actual bone strength. This is what the extreme CT scanner looks like. And we take pictures of your wrists and your ankles on both sides of your body. And I'm going to see if this works. Maybe it doesn't. Okay, there was a video of the scanner. But basically what happens is the scanner is just a localized scanner. It's not your whole body that's scanned. And you generally just put your foot or your arm into the scanner. The door gets closed. It takes about 10 minutes to do the scan, and then they move on to the next limb. And it generates a report like this. In Calgary, we've actually scanned a normal population already that have of all different ages, so that we have normalized data. We know what the extreme CT should look like for normal healthy patients, and we compare the hemophilia patients' results to these. So thank you. If you're interested in this extreme CT bone mineral density study, please talk to Ming or to Dr. Jackson, and I'm happy to answer any questions you might have.